السلام عليكم ورحمة الله تعالى وبركاته، كل عام وأنتم بخير. لقاءنا يتجدد مرة أخرى في سلسلة محاضرات الهارت فيلير. Today's lecture is Evaluation and Management of Pulmonary Hypertension and Left Side Heart Disease. As usual, we have exceptional heart failure specialist Dr. Mahmoud Abdou, Assistant Professor, Division of Cardiology from Emory University. Mahmoud, the stage of yours.
بارك الله فيك منصور. كل عام وانتم بخير جميعا. And I'm very excited today to give this lecture, and it will be about the evaluation and management of pulmonary hypertension and left heart disease, and that will be the majority of our focus, inshallah. I don't have any disclosures related to this talk. By the end of the talk, my objectives will be for all of us to leave the lecture learning the definition and classification of pulmonary hypertension. We will try to explain the pathophysiology and the diagnostic workup of pulmonary hypertension in general, and we'll hover over the overview and management of pulmonary hypertension, and that will be the bulk of our talk. I designed the talk. The title is Pulmonary Hypertension and Left Heart Disease. However, we're going to touch upon multiple other classifications of it. So let's start. And the definition of pulmonary hypertension is very easy. Sometimes when us as cardiologists, when we are faced by the word pulmonary hypertension, we sometimes freeze, we get intimidated, we get a little frustrated. This is a difficult topic. Is it something related to pulmonary that I don't know about? However, by the end of the talk, I will ask a question, more maybe a philosophical question, and see how all of you all feel about this. But simply, pulmonary hypertension is the elevation in pulmonary arterial pressure. This is defined by the elevation of mean PA pressure beyond the normal value of 20. In 2018, the Sixth World Symposium on Pulmonary Hypertension that was done in Nice, France, redefined pulmonary hypertension and gave it a definition of a mean PA pressure more than 20, contrary to the prior definition of more than 25. They had a separate definition for pre-capillary pulmonary hypertension, and we'll discuss these terminology in very great details in the next few slides. The pre-capillary pulmonary hypertension was defined as a mean PA pressure above 20 with a wedge pressure that is less than 15 and a pulmonary vascular resistance more than 3. For many years, the diagnosis of pulmonary hypertension was based on an arbitrary value of the mean PA pressure being more than 25. And that was understandably reasonable because of concerns of overdiagnosis and overtreatment. However, today there is growing evidence that many instances of pulmonary arterial hypertension associated with systemic sclerosis, for example, or chronic thromboembolism and chronic lung disease patients have, even with modest elevation of mean PA pressure between 20 and 25, they are very symptomatic and have severe exercise limitation and poor outcomes. But whatever the mean PA pressure cutoff that you use, and I think we should all use the mean PA pressure of 20 as our cutoff, it's important to emphasize that the value used in isolation does not characterize a clinical condition and does not define the pathological process per se. Now, throughout the talk, you will see this red ribbon, and it's an update, and I will tell you about it in a little bit. In August of 2022, just approximately 6 months ago, the European Society came up with a new guideline for pulmonary hypertension. It's a very hefty document with multiple pages, but a beautifully written document. And here they redefined the definition of pulmonary hypertension again. And now we have a mean PA pressure more than 20 at rest, and that's very important. However, they dropped the pulmonary vascular resistance from 3 Wood units to 2 Wood units. Now, the definition of pulmonary arterial hypertension, PAH, did not change. It still stays the same, mean PA pressure more than 20 plus a wedge pressure less than 15. However, the PVR is more than 2 versus 3. And again, same reason behind that is that before they were it was an arbitrary kind of this is the observation. However, more and more data showed that the threshold of poor outcomes and increased mortality and morbidity was associated with a PVR more than 2 rather than 3. These are the different WHO classification of pulmonary hypertension. The famous 5 groups, WHO group 1, which is pulmonary arterial hypertension. And within this group, you can see that it's further classified into, you have your idiopathic PAH, the heritable or familial PAH with the gene mutation of BPPR2. That's very, very famous. You have the pulmonary hypertension that's associated with drug and toxin induced, like methamphetamines, which is very important. Those associated with infections, especially if things like schistosomiasis, HIV, and connective tissue disorders, all within group 1 PAH. And this is very important. I'm emphasizing on this. When you say PAH, that means that you are defining group 1 disease of group 1 PH. So pulmonary hypertension group 1 is pulmonary arterial hypertension PAH. All the other groups do not have the designation of PAH. They have the designation of PH, which is pulmonary hypertension. Those include group 2 pulmonary hypertension, and that's the pulmonary hypertension related to left heart disease, either heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, or associated with left valvular heart disease, associated with with aortic pathology or mitral valve pathology. Some congenital heart disease are defined within group 2 pulmonary hypertension. Group 3 pulmonary hypertension is that group that's related to pulmonary disease and lung disease, COPD, asthma, alveolar hypoventilation disorders, exposures to high altitude, all those cause pulmonary hypertension. Group 4 disease is a unique group of pulmonary hypertension, and that is related to chronic thromboembolic pulmonary hypertension, and also known as CTEPH. Of course, we as physicians in general, when we don't know anything, and instead of saying we don't know, we either designate a different name like essential or idiopathic or something, or we just put them and lump them in a group. And that's why we have group 5. Group 5 pulmonary hypertension is those patients or those conditions that we don't know and we don't understand the clear mechanism of it. Metabolic disorders, hematological disorders, so on and so forth that cause pulmonary hypertension. We just group them in group 5. Again, the red ribbon, that means there's an update from the newest guidelines a few months ago, and that is for the first time, and actually in keeping with some recommendations from the NICE group in 2018, the idiopathic PAH group now have a separate, 2 separate subclassifications, and those are non-responders to vasoactivity testing and acute responder to vasoactivity testing. And they felt that because the disease process and the management and pathophysiology and the mortality in these patients are different, they deserved subclassification. And don't worry, I'm going to explain all these terminology in few slides. Another update is group 3. Group 3, which is related to lung disease. Previously, we had sleep disordered breathing, obstructive sleep apnea being a major contributor and as a pathophysiological and etiological factor for pulmonary hypertension. However, studies over and over again showed that the sole nocturnal obstructive sleep apnea does not cause pulmonary hypertension. However, pulmonary hypertension is as a result of hypoventilation, either hypercarbia or hypoxia. Those are the ones if the sleep apnea is severe enough to cause hypercapnia during the daytime or hypoxia, severe hypoxia, that's when it causes pulmonary hypertension. However, if the sleep apnea is just mild or moderate sleep apnea, it does not cause severe and significant pulmonary hypertension. That's why they crossed out that and they called it hypoventilation syndromes. This is a very important slide, and this shows the classification of pulmonary hypertension within amongst the 5 WHO groups. And as you can see, it doesn't require a lot of it's really obvious that 70% of pulmonary hypertension is related to left heart disease. And the rest, the remainder 30% is all the other causes. 10% of those is group 3, which is lung disease. PAH, we're going to talk about that in a little bit, only constitutes 3% of the patients. CTEPH is around 2 to 5% of the patients, and 15%, 10 to 15% remain unknown. So this is a diagram that I love drawing to my residents and fellows on rounds. And here we will try to explain these definitions and terminology that we use. What's pre-capillary pulmonary, what's post-capillary, what's group 1, what's group 2. It's all confusing sometimes. However, let's just take a step back and let's imagine the circulation as a tube. We will start, let me put on my pointer, and here you go. So the pointer is on. So let's imagine the circulation as a tube. Let's start with the aorta and trace backwards. From the aorta, the left ventricle, the left atrium, then the pulmonic veins. From the pulmonic veins come directly from the pulmonary capillaries associated in the, located in the lungs, the pulmonary artery that comes from the RV, the RA, and the vena cava. So focus your attention on the middle part, and this is the lungs. So anything within the lung, any pathology within the lung has the pulmonary capillaries. So anything in the lung, that's group 3 disease. We got WHO group 3 pulmonary hypertension. That's easy. So if these are the capillaries, anything before the capillaries is pre-capillary pulmonary hypertension. And that's your group 1 PAH. Pulmonary thromboembolic pulmonary hypertension, CTEPH, which is group 4, is associated here, is located here, because it's pulmonary artery, right? It's pulmonary thromboembolic disease. So that's also pre-capillary pulmonary hypertension. Anything after the capillaries, meaning in the heart, that's post-capillary pulmonary hypertension, and that's your group 2 pulmonary hypertension. Okay. I'm going to spend a few slides and a few minutes, if you allow me, and talk about group 1 pulmonary hypertension, or PAH. PAH is a hot topic, and the reason why is that there's a plethora of treatment and medications that treat this, and that's why a lot of people think about this a lot and associate pulmonary hypertension with PAH. However, believe it or not, PAH, or group 1 pulmonary hypertension, is a rare and orphan disease. It constitutes only 2 to 3% of patients with pulmonary hypertension. It affects 15 to 50 patients, that's all, per million of the population. In the whole United States, there's registered around 5,000 to 5,500 cases. So it's not a very common disease, it's a rare disease, and I like the word orphan disease because it's not that common. However, it takes a lot of press. Pulmonary arterial hypertension, or PAH, this is a very famous diagram. And this demonstrates the 3 major pathways involved in the abnormal proliferation and contraction of smooth muscle cells of the pulmonary artery in patients with PAH. These pathways correspond to the important therapeutic targets in the condition and play a role in determining which of the 4 classes of drugs, endothelial receptor antagonists, nitric oxide, phosphodiesterase type 5 inhibitors, prostacyclin derivatives will be used. Now, I want to bring to your attention that although these 3 pathways that have been described in the potential pathophysiological pathway of the disease, this illustration is very helpful to know the therapeutic targets used in treating PAH. There is no solid evidence that overexpression of endothelin 1, or inadequate production of nitric oxide, or the deficiency of endogenous prostacyclin actually happens in the disease process of PAH. There is no proven evidence. However, there is evidence that targeting these pathways with medications helps patients with PAH. Rather, I'd like you to think about PAH as a vascular cancer. It's out of proportion or out of control proliferation of pulmonary vascular intima and smooth muscle hypertrophy, along with the reduction of apoptotic mechanisms with the enhancement of stimulators and depression of inhibitors of such proliferation. So let me just rephrase this again. If you have increased proliferation and decreased apoptosis, isn't this the definition of cancer? And that's exactly what it is. PAH is a vascular cancer. This is a beautiful article written in 2016. If people are interested, it really explains and dives into details about how the vascular proliferation happens in PAH and the mediators and the genes and overexpression of certain genes. Beautiful paper if you're interested in this. Histopathologically, PAH involves the intimal thickening and a narrowing of the cavity of the pulmonary arteries and the formation of plexiform lesions. If you are faced with a board question that says plexiform lesions on a histopathological slide, immediately that's a pathognomonic of PAH. This what goes in my mind, this very complicated, complex algorithm immediately goes in my mind. I kind of committed this to my memory. However, I do not encourage you to do so. This is not meant to be memorized nor followed in order, but this is the ACC-AHA diagnostic algorithm to evaluate patients with suspected pulmonary hypertension. It really, if you look at it carefully, it really defines patients that have PAH into those 5 WHO class schemes. The Europeans last year came up with a more simplified algorithm, and this is a beautiful algorithm that you can follow. And this is anybody who has suspected pulmonary hypertension, follow this algorithm and it will take you to where you want to be. We are in the cardiology realm, so we need to talk about what do we see in patients with pulmonary hypertension from an echocardiographic standpoint. RV enlargement, there's maybe RA enlargement, septal straightening or the interventricular septal straightening with a D-shaped septum, the loss of IVC, respiratory collapse. You have significant amount of tricuspid regurgitation. You may see pericardial disease and pericardial effusions, and usually signs of RV systolic dysfunction. And this is also another beautiful slide that kind of summarizes these echocardiographic signs very beautifully. And this is straight out of the guidelines from the European guidelines from last year. Right heart catheterization is usually done in people who are suspected to have pulmonary hypertension. Not only it enables us to measure the left side pilling pressures and the pulmonary arterial pressures, but it also enables us at a good opportunity for us to do a vasodilatory therapy. And it's required for almost all patients with suspected pulmonary hypertension. So if you perform a right heart catheterization and you see that the pulmonary pressures are high, above 20, and the wedge is less than 15, you're suspecting pre-capillary pulmonary hypertension, right? So if your suspicion is to PAH, you absolutely need to perform an acute vasoreactivity testing. You are challenging the pulmonary vasculature with a vasoreactive agent. Those who respond, we call them acute responders to vasoreactivity testing, and those patients will benefit from trial of high-dose calcium channel blocker therapy. Those who do not respond, and that constitutes the majority of patients, they need to be considered for other therapies for PAH after establishing that diagnosis. So very important slide, and we'll define what a response to a vasoreactivity test in the next slide or two. I will tell you in my career so far, doing this for quite a while, I have not seen but 2 or 3 patients respond to acute vasoreactivity challenge. So If you don't find one, don't be disappointed. These are the 3 agents that are commonly used for vasoactivity testing. I like to use nitric oxide. That's what we use in our institution. Inhaled NO, you give 20 parts per million, 40, and then you 80, and you wait. There's a pre-specified protocol that you use, and if they respond, they are considered responders. If they don't respond, then they are non-responders, of course. What defines acute response? This is a very important slide. Fall in the PA pressure less than 10 to an absolute value less than 40. We're talking about the mean PA pressure. So if the mean PA pressure drops 10 points to less than 40 millimeter mercury, and the cardiac output did not change or in fact increase, that defines a responder. And you have to have all 3 in order for you to qualify as a responder to vasoactivity testing. For those who respond, calcium channel blockers, high dose nifedipine is usually used, and they have a very good outcome out of that. Other therapies that are used for treatment of PAH, we are not going to spend a lot of time on this. Prostacyclins, endothelin receptor antagonists, phosphodiesterase inhibitors, and soluble guanylate cyclase stimulators. Prostacyclins is the mainstay of therapy for PAH. In order for you to have a successful PAH treatment or program, you have to have an infrastructure to administer parenteral prostacyclins, epoprostenol, treprostinil, so on and so forth. And this is kind of a summary of the medications that we use within the group and their usual doses for your reference. The ERAs, bosantan being the very famous one in the old, it's an old medication. Now we're in a new generation ERAs like ambrisentan or macitentan. Those are used as well. Phosphodiesterase inhibitors, the infamous sildenafil and tadalafil, that are in higher doses are used for erectile dysfunction. In lower dose, they are used for PAH therapy. And then you have your soluble guanylate cyclase stimulators, riociguat, which is used in conjunction with others. It's also used, and this is also important, especially for folks who are taking boards, that riociguat is the only therapeutic agent that's used for CTEPH patients if those patients are inoperable. So let's shift gears to the main bulk of the talk, and that will be group 2 disease, which is group 2 pulmonary hypertension. Pulmonary hypertension due to left heart disease, PH-LHD. And this is a slide to show how prevalent this is in the community. So this is a study done back in the days in 2009 by the Mayo Clinic, and it showed that pulmonary hypertension is very prevalent. This is a community-based study of 244 patients with heart failure with preserved ejection fraction. The PA pressures was estimated by echo. In patients with heart failure and preserved ejection fraction, approximately 83% of patients had pulmonary hypertension compared to the control group that had hypertension with no heart failure. So very prevalent in the community. And the question always comes, why does left heart disease, why does heart failure cause pulmonary hypertension? Why does pulmonary hypertension happen due to left heart disease? And the answer is very straightforward, believe it or not. It is the higher the left atrial pressure, the higher the PA pressure by passive filling backstream into the pulmonary circulation. This is another Mayo Clinic study, estimated that the prevalence of pulmonary hypertension in people above the age of 65 is approximately 12% higher in the rest than the remainder of the population. The study showed that the increase in age is an individual and independent marker for worse outcomes in patients with pulmonary hypertension, even in the absence of cardiopulmonary disease. So if we have 35 million people above the age of 65 in the US, 4 million will probably have pulmonary hypertension. 68% of those, meaning 70%, will have due to heart disease. So you're talking about 2.8 million people who have pulmonary hypertension. This carries significant burden and impact, as we will see in the next few slides. Wide range of prevalence, probably related to various definitions of pulmonary hypertension and modality of diagnosis and heterogeneity of study population. But nonetheless, in both forms of heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, pulmonary hypertension appears to be prevalent in a non-negligible percentage of patients. Bottom line is this is a very common comorbid condition in patients with heart failure. And that's why it's relevant to our specialty as advanced heart failure specialists. Why is this important? Is it important just to mention that we have high pulmonary pressures? No, these are the results of a study of patients with different underlying etiologies of cardiomyopathies, including myocarditis. The mortality was associated with higher mean PA pressures and higher wedge pressures. But if you notice that it's in a linear fashion, meaning the higher these values, the worse the outcomes. However, the relationship between pulmonary vascular resistance, PVR, and mortality in patients with pulmonary hypertension and cardiomyopathy appears to be in a threshold fashion. And you can see up to PVR of 3, the mortality didn't change much. But once you hit PVR of 3 and beyond, these patients face worse outcomes. And probably that's why for a long period of time, for decades, we are defining pulmonary hypertension as a PVR more than 3. However, there's more evidence. These are older studies, but there's newer studies that are suggestive that PVR more than 2 also carries a bad prognosis. All right, another classification slide, and this is, I want to spend a little bit more time on this. So group 2 pulmonary hypertension, as you can see by my pointer, heart failure with reduced EF, heart failure with preserved EF, and valvular heart disease cause pulmonary hypertension, group 2. Then you further define these into, we used to call this passive PVH, pulmonary venous hypertension, and mixed PH. That was before 2015. From 2015 going forward, we changed these names. The PVH, or passive pulmonary hypertension, now is called isolated post-capillary pulmonary hypertension, IPCPH. And this is defined by a mean PA pressure of 20, not 25. This is an old definition. A wedge pressure more than 15, and a transpulmonary gradient less than 15, and a PVR between 2.5 to 3. If your TPG is more than 12 to 15, let's make it simple. If the TPG is more than 15 and your PVR is more than 3, in a patient who has a mean PA pressure of more than 20 and a wedge more than 15, this is combined pre and post capillary pulmonary hypertension, CPCPH. That's further subdivided into reversible, if this is still early enough. And this reversibility is different than the reversibility that we talked about earlier. This is reversible by vasodilators or diuretics. If you're able to reverse the TPG and the PVR to less than 15 and less than 2.5 to 3 respectively, that's still reversible, combined pre and post capillary pulmonary hypertension. If you're not able to reverse them, that's called fixed combined pre and post capillary pulmonary hypertension. In the cath lab, when you do right heart cath, this is very important, and you can use this as a reference. It all starts with high left atrial pressure in all forms of post-capillary pulmonary hypertension. In IPCPH, with the passive congestion alone will cause PA pressures to rise. No vascular remodeling has occurred yet. As the disease state continues and congestion persists, remodeling begins to happen and causes the PVR to start to rise. Early on, it's still in the reactive phase. Here's where your diuretics and your vasodilators may result in improvement in hemodynamics. But once the remodeling is complete, it will become an irreversible process, and CPCPH occurs, and this is a difficult to treat situation with high mortality and poor prognosis. The ultimate sacrifice in pulmonary hypertension with left heart disease is right ventricular failure. And the way this is caused is by backward transmission and backflow phenomena. I like to think of it as a water hose. There is a plug downstream, elevated left atrial pressure. This causes congestion and increase in the volume upstream from the LA to the pulmonary veins, to the pulmonary capillaries, to the pulmonary arteries, and eventually ends up in the RV. As we all know, the RV is a low pressure chamber. It can handle volume very well. Initially, when there's only passive congestion and increase in volume. However, the RV can accommodate this, and it starts to dilate, but maintains its function relatively well. But as the left side system remains poorly loaded and the pulmonary vascular remodeling starts to happen, vasoconstriction in the pulmonary vasculature is irreversible, the RV becomes overwhelmed with the high pressure that it's faced, which is not meant to handle. And the RV pays the hefty price of the transaction and will start to fail. Here, the disease process resembles more of PAH, pre-capillary pulmonary hypertension, hence the name combined pre and post-capillary pulmonary hypertension, CPCPH. At that point, pulmonary vascular compliance decreases and there is no great response to vasodilators. What happens? Backflow from the right side to the kidney bed or renal congestion, hepatic congestion, and all the manifestations of right heart failure happens. And at that point, biventricular failure will lead to death. Not only hemodynamically and pathophysiologically, CPCPH acts as pre-capillary PAH, survival and mortality of this form of PH resembles that of PAH. Pay attention here, these are the control group. Folks who have isolated post-capillary pulmonary hypertension, they relatively have still a little better prognosis, as the more the disease progresses. You can see here in this dotted line, this is fixed CPCPH. And notice that at almost 48 months or 2 years, the mortality, actually before that, 24 months, the mortality of it approximates the mortality of folks who have WHO group 1 disease, PAH. Even histopathologically, they look the same. These are a few slides of histopathological. This is a patient who has fixed CPCPH with a TPG more than 30, and this is a patient who has idiopathic PAH. Look at the resemblance. Look at the intimal thickening and the narrowing of the vessels. The only difference between them is that these patients have plexiform lesions, that therefore they're called PAH. These patients here, because of group 2, do not have those plexiform lesions. Arterialization of pulmonary veins with double elastic lamina is a very known phenomena, and this is something that's usually overlooked. Pulmonary veins, like pulmonary arteries, undergo remodeling, and this is the hallmark to and unique to group 2 patients. Group 2 pulmonary hypertension have pulmonary vein remodeling along with pulmonary arterial remodeling as well. And this has further implications in the utility and future therapeutic options for these patients. Let's talk a little clinical stuff. And this is the list of how do you initially diagnose and evaluate pulmonary hypertension. Classic EKG, you can see signs of RV strain. Cardiac imaging, we usually start with an echocardiogram. There's some echocardiographic features that I mentioned and I showed you earlier in the slide that points you towards the diagnosis. Pulmonary function test needs to be done to make sure that this is not group 3 disease. 6-minute walk testing, this is the test that's been used in clinical trials. And then you resort to your invasive hemodynamic assessment with the right heart catheterization, with fluid challenges and exercise challenges. Not every patient needs a right heart cath to establish the diagnosis. However, right heart cath and invasive hemodynamic data is pivotal in situations where persistent symptoms happen, continuous rise of PA pressures despite management of underlying etiology and condition. And a right heart cath is necessary for a potential fluid challenge or exercise challenge if resting measurements are not helpful in explaining the clinical condition. We use right heart cath to assess measured parameters. The right atrial pressure is important. PA pressures, of course, systolic, diastolic, and mean, and we check the wedge pressure. From there, we derive our derived parameters: transpulmonary gradient, diastolic pulmonary gradient, cardiac output and index, PVR, and PA compliance. But I have a ribbon here that has an update. So I wonder what that is. In the 2022 guidelines, we crossed out the diastolic pressure gradient due to that it hasn't been consistent in showing any meaningful mortality or morbidity or change in clinical practice. Therefore, the European guidelines have eliminated that from the invasive hemodynamic assessment of pulmonary hypertension. This is a table to kind of show you how these parameters are derived, and the equations and the normal values. And of course, the diastolic pressure gradient should not be used. Let's talk about the management of this disease and how can we treat these patients. There is one central principle in management of group 2 pulmonary hypertension, and that is management of the left atrial pressure, followed by the two co-principle, management of the underlying substrate, then followed by attempting to induce vascular remodeling. The long-term management emphasizes the continuous treatment of each of these three layers simultaneously, forming this three-pronged approach in the management of pulmonary hypertension with left heart disease. This is a beautiful and promising treatment model work done by and proposed by Dr. Ray Benza, one of the prominent experts in the field in pulmonary hypertension. This three-pronged approach emphasized the basic fundamental management paradigm strategy in treating patients with pulmonary hypertension with left heart disease, which is continuous and ongoing frequent monitoring, frequent clinical visits, and evaluation and implementation of individual thoughtful therapy. Let's talk about them in one by one. The management of left atrial pressure, the rate and rapidity and duration and magnitude, and how fast and how high the LA pressure rises really is important and identifies the chronicity of the problem. And the repeated increase in LA pressures with acute and chronic increase in PA pressure leads to worsening RV function and RV failure and frequent hospitalizations, eventually leading to CP-CPH. And when you have CP-CPH that is fixed, kind of it's almost you're approaching the end of the road. Management of left atrial pressure, as we all know, the cornerstone and the foundation of medication is diuretics. Diuretics is the key success of that is to decongest the left atrium and the left ventricle, and therefore relieving the pressure upstream for the right ventricle, and therefore improving the pulmonary pressures. The nitrates, less commonly used, can be used in certain conditions. Surgical and mechanical unloading of the left atrium. Left atrial pumps have been used recently over the last year or two. There's a couple of pumps that have been used in heart failure with preserved ejection fraction that showed conflicting data. One trial was very positive, the other trial was very negative, so we don't know still, it's still experimental. Interatrial shunts, not commonly used in the United States. Our colleagues in Central and South America have more experience on this, and we're trying to kind of figure out how to implement this in selected patients. Of course, LVADs, left ventricular assist devices, is a key success in consistently unloading the left ventricle. Of course, the indication for LVADs is still the usual ACC/AHA stage D heart failure, and it's not pulmonary hypertension in per se is not an indication for implanting an LVAD. Management of the underlying substrate. This really comes down now to pure cardiology, and that's coming back to what's the root cause of the problem, and the root cause of the problem is usually heart failure. So guideline-directed medical therapy for heart failure with preserved ejection fraction, heart failure with reduced ejection fraction. Now, in 2023, I can say guideline-directed medical therapy for heart failure with preserved ejection fraction. Before, we did not have any much success, but now we do. Utilize cardiac resynchronization therapy, CRT, whenever is needed. Strict blood pressure control. Manage your comorbid conditions, obesity, manage the diabetes, AFib. If the patients have obstructive sleep apnea, absolutely needs to get that treated. Your valvular lesions, if there's valvular lesions, they need to be corrected if there's an indication to surgically correct these lesions. If the patients have hypertrophic cardiomyopathy and there may be benefit from myectomy or alcohol septal ablation, definitely that's something that you need to think about. And of course, if patients have stage D heart failure and you need to refer them for an LVAD or transplant, please do so. This is an old study that showed regression of pulmonary hypertension after valve surgery. This is a very old study in the 1970s. And we saw that over time, the pulmonary pressures in patients with mitral stenosis, when you fix the mitral valve, over time, the pulmonary hypertension starts to get better. And we see very similar results with LVAD as well. By using pulmonary vascular remodeling agents, one of the very famous ones is sildenafil, for example, or others like bosentan or macitentan or so on and so forth. If you use these agents prior to controlling for left atrial pressure and addressing the underlying substrate, you're really setting yourself up to failure. The non-conditioned left ventricle, the failing left ventricle, or the stiff left ventricle, HFrEF or HFpEF, with high left atrial pressure is not ready to receive extra blood flow that is a result of pulmonary vasodilators. So here you go, you have a stiff left ventricle or a failing left ventricle, and all of a sudden you open the gates and you flood those ventricles with blood coming from the right side by increasing and promoting pulmonary vasodilation. This actually causes what we call a ventilation perfusion mismatch and will lead to RV ischemia and patient compromise and death. From my experience, I get referred a lot of patients for pulmonary hypertension. For patients referred to me for group 2 pulmonary hypertension, I actually spend a lot of times stopping these medicines than putting patients on these medications. The hemodynamic condition of the left ventricle is way suboptimal when they come and see me, and there's unaddressed valvular abnormalities, unaddressed heart failure. Therefore, I stop these agents, optimize the heart failure, optimize their volume status, refer them for valvular interventions, either surgical interventions or percutaneous interventions, and patients, believe it or not, start to feel better and stay out of the hospital. What do we know about pulmonary vasodilator agents in management of heart failure? We know that every single agent that we used, from the prostacyclins to the PDE5s to the riociguat, everything have been negative. 30 years of negative results in clinical trials that showed that using agents for pulmonary hypertension in patients who have left heart disease is associated with worse outcomes and increased mortality. Now, you can come back and argue, if you want to go dive in these trials, that these trials did not control for pulmonary hypertension and did not have protocols to control for left atrial pressures. Let me show you a few other trials. Even if we did control for pulmonary hypertension in heart failure patients, trials utilizing pulmonary hypertension specific therapy still fail to yield strong evidence of success. Other large randomized controlled trials were with not so convincing results, and as a result, even in the latest guidelines in 2022, there's not been a recommendation for use of any of the medicines that I showed you before. Remember those slides where I showed you the prostacyclins, sildenafil, tadalafil, ERAs, riociguat? These are not recommended in the use in pulmonary hypertension with left heart disease. Now, unless it's in a clinical trial, that's different. And we'll talk about this in a little bit. To be effective, though, I think there is a role. However, we're still in very infancy in this. This is still in clinical trials. To be effective, using drugs that will affect vascular remodeling and left ventricular remodeling and unloading, those that work on the cyclic GMP PKG axis leads to improved ventricular vascular coupling. PDE5 inhibitors like sildenafil and tadalafil, riociguat, which is an SGC simulator, lead to increased cyclic GMP and NO. resulting in improved coronary and systemic endothelial function. The results in animal models propose decreased LV hypertrophy, decreased fibrosis, and improved left ventricular relaxation. However, this is beautiful in theory and in animal models. However, clinical trials have been ongoing so far with this, and hopefully we'll get some positive results. The results so far in few clinical trials that I'm involved in are not that promising. These are few clinical trials that are undergoing. Some of them have been stopped during COVID. This is trying to see if we can use PAH therapy in heart failure patients. So there is one clinical trial that we are starting to enroll for heart failure with pulmonary hypertension group 2 in folks with preserved ejection fraction with the use of riociguat. So this is the dynamic study. We'll see how that works. So the three-pronged approach: left atrial pressure management, treat the underlying substrate, and think about pulmonary vascular remodeling, continuous and consistent monitoring, multimodality approach, multiple touch points with the patient. You're treating and monitoring simultaneously. So this requires exhaustive resources, a lot of resources. So if you're talking about monitoring your left atrial pressure, you're talking about clinical visits, vital signs, physical exams, labs, daily weights, weight-based diuresis, neurohormonal monitoring, BNP. We demonstrated this in the guided trial. Home telemonitoring was not very successful. You need the repeat imaging. You need repeat testing, exercise testing, repeat hemodynamics. Not everybody can get, actually repeating it right heart caths and hemodynamics every 2 or 3 weeks is not practical, and it will not give us a snapshot of hemodynamics in time while the patient is supine and resting. That's how usually you get them in the cath lab, but it's not reflective of the normal minute-to-minute activity that these patients undergo. Echoes, we can monitor them with echo. However, this is one of my take-home slides. Echo assessment in pulmonary pressures during using the TR velocity is the usual initial indication of presence of pulmonary hypertension. However, a word of caution: this is an important caveat. One of my important take-home points: once you diagnose pulmonary hypertension, you really do not want to monitor the response to therapies by the use of echo, because this is one study done in 2011. They took 160 patients and assessed correlation of right heart cath with echo in measurement of pulmonary artery pressures in patients with established pulmonary hypertension disease. And you can see the data is all over the place. There's no correlation whatsoever, and the inaccuracy was almost 50%. So it's a flip of a coin. So you will get them right in 50% of the group. Similar finding, there's an exact same trial done by the group from Hopkins, and showed exactly this similar results. So once you diagnose pulmonary hypertension, you can use echo. Echo has the major role in pulmonary hypertension. Use it for diagnosis, for screening. But once you get to an established diagnosis of pulmonary hypertension, my take-home message is be cautious with trying to follow your pulmonary pressures and the response to your treatment methods by using the TR velocity on echo. I know this slide will stir a lot of discussion later on after I'm done with this talk, and we'll be happy to debate. Disease monitoring. This is a novel approach. It's not so novel much. It's been around for the last 15 years or so, and this is the CardioMEMS. CardioMEMS is a over-the-wire implant that you go through a venous sheath through either the IJ or the femoral vein. You go over 11 French. It's a standard cath lab procedure, and you deploy this beautiful sensor in the PA. This small itty-bitty sensor that's less than the size of a quarter enables you to monitor PA pressures while at home. The infamous Champion trial and back into the 2009-2010 era, we learned that there is a window of opportunity to prevent clinical decompensation and hospitalization. And this can be detected way in advance by the use of CardioMEMS. Almost 20 to 30 days. So what do we learn from the Champion trial is that PA pressures start to rise, filling pressures start to increase, and 20 days to 30 days when your symptoms start to develop. So you have this beautiful window of opportunity here to intervene by modulating your therapy, and that can be only detected if you have something that you can sense the pressure with, and that's what CardioMEMS does. Let me show you a snapshot of a patient of mine, and this is a patient, I will never forget this patient. She was on the dot, every 3 to 4 weeks gets admitted for heart failure. Every 3 to 4 weeks gets admitted for heart failure. They diurese her, get her tuned up, send her home. 3 weeks, she comes back. I saw her one time, I said, let me implant a CardioMEMS for you. So we put a CardioMEMS right here. You can see her PA pressures are elevated at day 0. And with time and with continuous monitoring, you can see that the pressure started to drop. She transmits almost every day, and my team in my office will follow up with a phone call. Mrs. X, go ahead and double up your diuretics. Mrs. X, oh, your pressures are falling today, hold your diuretics. Do this, do that. And you can see since I implanted the device for a long period, almost a year and a half, we did not see her face in the hospital. In fact, I only saw her 3 or 4 times in clinic, and this is a snapshot of her PA pressures by CardioMEMS. This is exactly what I see in my office or on my computer after the patient transmits the data from us from home. We're at the end stretch here. A few words on group 4 disease, group 4 pulmonary hypertension, chronic thromboembolic pulmonary hypertension, or CTEPH. Patients who developed PEs, those of them who are unfortunate that the PEs persist and they start to get organized and fibrosed. You will have persistent thrombus and fibrin there. Those develop pulmonary hypertension, understandably, and this is pre-capillary pulmonary hypertension. The only way to treat this, actually, or the definitive way to treat this, is by surgery, extensive surgery called pulmonary endarterectomy, where the surgeons go in and find a track within the pulmonary arteries and the pulmonary vasculature and start to extract all that fibrin. This was a clot before, but now you can see that it became fibrosis. The surgery is a very highly sophisticated surgery that's offered only in selected centers across the United States. Well, actually, when I was in training and fellowship and residency, we only had one center in the United States. That was University of California in San Diego. Now it's kind of became more and more, people are more and more comfortable with it. My institution offers this as a therapy for folks who are, it's a very high risk surgery. Of course, a lot of patients, end up on ECMO after that and shock for a period of time, and it needs the infrastructure to accommodate these very sick patients. Those who are not eligible for surgery, balloon pulmonary angioplasty can be offered through the cath lab. It's a cath lab procedure. And for those who are inoperable, riociguat actually has been shown to improve symptoms for these patients. This is an updated slide from the 2022 ESC guidelines. Beautiful slide. It summarizes everything. Almost all my talk can be summarized in this one slide. The 5 groups of pulmonary hypertension, the prevalence of each group, and what the therapeutic strategies that you need to do. And of course, pulmonary hypertension, the price is paid by the right ventricle. Right ventricle is the one who pays the price, and patients die from RV failure. This is the link and the snapshot of the article. I encourage those who are interested to glance on it. It's a big document. However, it will provide a lot of information. Well done and a beautifully written document. So in summary, pulmonary hypertension is a disease that's very prevalent, carries high morbidity and high mortality. PAH, group 1, pulmonary arterial hypertension, is a rare disease with a poor prognosis, but it has unique and selective therapies. Therapies that are used for PAH are not successful and should not be used in patients who have pulmonary hypertension with left heart disease. Trials of use of PAH therapy, sildenafil, tadalafil, macitentan, riociguat, so on and so forth, that are used in heart failure are ongoing. So, these agents should not be used outside of clinical trials. Make all efforts to identify the etiology of pulmonary hypertension. Treatment of pulmonary hypertension is based on the correct diagnosis, etiology, and functional status. It requires a lot of collaboration, a lot of infrastructure, and the key is early referral to either a pulmonary hypertension specialist or pulmonary hypertension centers. And that's actually been shown, and they talk about this in the guidelines, that it's shown to be effective in improving outcomes. And with that, I will stop, and I'll be happy to answer any questions.
Outstanding presentation, Mahmoud, as usual. So now we'll open the stage for discussion. If anyone has any questions, you can raise your hand, or you can write your question in the chat box. Let me see. I believe one person raised their hand. Ayman, اتفضل Ayman.
السلام عليكم محمود, مشكور جدا. Excellent presentation. The topic very complex. I think you covered very nicely with the new update. For example, on the BVR, it's new to me that they went down from 3 to 2. And I think it falls in the same idea or concept, going from the 25 for mean pressure to 20 is to screen and pick up the disease early to intervene. I think you alluded to the new European guidelines update, which is excellent document. I highly recommend everyone to go on. Surprisingly to you, I'm not going to argue with you the echo use for pulmonary hypertension. I totally agree with you. I think echo is a good tool and excellent for screening, but not to establish the diagnosis or follow up. So I think this is a very important point. There's some formula that can help some people to kind of get an estimate for the mean pulmonary arterial pressure when they don't have access to hemodynamic study. When you use the RVSP or pulmonary arterial systolic pressure, you multiply that 0.6, and you can guys hear me, and you add 2 to it. So kind of roughly help you with that. I think the use of the echo beside the screening is you look for the signs of left side heart disease, like left atrial enlargement, LVH, the filling of pressure, IVC. So these are helpful. Now, my question to you, Mahmoud, I know you kind of make it clear for all the audience today that the use of the pulmonary arterial hypertension, PAH, like the prostacyclin pathway or the nitric oxide pathway, like the phosphodiesterase inhibitor, and also the endothelin-1 agonist, it's not proven to be used for pulmonary hypertension due to heart disease, which is type 2, and the most common one. I like the slide that you showed. This is the most common type of pulmonary hypertension is left heart disease, because medicine common is common. My question to you, is there a role for one of these agents in patients with mixed disease when you're not sure that this is like purely left side heart disease that leads to pulmonary hypertension? You're not sure. Patient has some element of maybe pulmonary hypertension or COPD. I would like to get your intake on that for mixed type. Thank you.
Yeah, that's a good question, and it's very common scenario. Remember, during a talk or a lecture like this, it's good that we have this talk about group 1 and group 2 and group 3 and so on and so forth. However, in clinical practice, patients sometimes do not fit one category or the other. They come in, like you mentioned, a mixed disease picture. And those are usually the ones that end up in my clinic, for example, for, they've been seen by multiple people before, and then they come in and, now you're faced with this very complex situation that you don't know what to do. And have I used these agents or one or two of these agents in these patients? And the answer is yes, I have. And yes, I will think about them. However, these has to be done in a very selected way, and only after I correct for the underlying cause or the predominant cause. For example, I will tell you a patient who's in their 60s, mid-60s, diabetes, morbid obesity, high blood pressure, and chronic diastolic heart failure with preserved EF. EF was 55 to 60%. And they came in and has COPD and came in for a referral for pulmonary hypertension. I examined the patient, and the patient clearly is short of breath. Of course, he has many reasons for this shortness of breath and dyspnea. But strikingly on exam, which is I was not surprised, the patient was very volume overloaded. So if, for example, you are tempted at that time and you do a right heart cath and you cath the patient, and the PA pressures are in the 70s, so it's systolic in the 70s, or 70/40, for example. That's very high pulmonary pressures. And you're tempted to start something and, let me just reduce that pulmonary pressure. You set yourself up for problems. Now, what usually happens is I bring this patient in, tune them up, optimize their volume status, control their diabetes, control their blood pressure, treat their sleep apnea, refer them back to pulmonology to take a look at their COPD, make sure that they're all optimized from that nature. Repeat my hemodynamics again. If I find them that they're suitable now, they are in better control, their adherence to medication is better, they form a trust, I can now monitor them. There's a plan B in place. Cautiously, I will start a sprinkle of sildenafil, for example, with these, make sure that they tolerate it well under direct supervision with me, frequent visits, so on and so forth. A lot of times I will use cardiomems in these patients because that way I can monitor their pressures from home, and with some success. These patients are complex, and setting the expectations that I will probably not treat their dyspnea completely should be addressed with the patient before to set expectations. But yes, there is role in use of some agents, especially the PDE5 inhibitors. I would not recommend the ERAs or riociguat or so on and so forth, but the PDE5s, you may use it in very selected patients with mixed disease.
في عندنا الدكتور عماد تفضل، ممكن تسأل سؤالك يا عماد. عماد إذا كان في إمكانية تسأل السؤال.
تقريبا أيمن posted the answer.
I think he wants that formula. It's roughly. If there's no other question, Mahmoud, what's your advice to who should manage pulmonary hypertension? And this is not like cardiologist or pulmonologist. Should every institution have a special kind of specialist to deal with that, or you think everyone can manage this disease?
Yeah, remember I promised you that I will ask a philosophical question at the end of my talk, and you hit the nail in the head. So let me ask you, Ayman, after what you heard from me today, is pulmonary hypertension a cardiac disease, a lung disease, or a vascular disease?
That's a very good question. It depends.
Question.
In general, yeah, it depends
let
on
me,
the HR.
Let me help you.
ممكن أنا لو ندخل محمود أنا نقول it's all of the above، بس أنت قلت 70% is a heart disease, at least from the subclassification. Left side heart disease 70%, but if you think about it, it's all of the above.
let me
You're gonna bring that slide. I know.
Let me
You're gonna
bring
that slide.
let me bring the slide.
vascular slide.
Let me bring the slide, and let me see. We can have a discussion.
But you're not saying the vascular surgeon will manage this.
La. Remember, we are cardiovascular. We are board certified in cardiovascular disease, right? So looking at the disease itself, the disease and the pathophysiology of pulmonary hypertension, whether this is PAH, this is PAH right here. Oh, let me put my
no, Mahmoud. So no, I see. No, I'm not talking about pulmonary arterial hypertension.
Hold on. This is PAH. This is PAH, and this is PH from left heart disease.
Pathology is the same.
Don't you think the pathology is the same? The remodeling is the same. One involves the pulmonary arteries and one involves the pulmonary veins. But that's the disease process. Now, what triggered the disease is different. What triggers the disease in group 3 is a lung pathology. What triggers the disease in group 2 is a heart pathology. What triggers the disease in group 1 can be connective tissue, can be infectious, can be hereditary, can be idiopathic. So Mansour's answer is probably the most close to be accurate. It's all of the above. To answer your question, Ayman, I do believe that having a group that deals with pulmonary hypertension is very essential, especially if you're talking about tertiary, quaternary care, cardiac care for patients with heart failure, or in general, cardiac patients in general. Having a core group of physicians, these physicians, I think, in my opinion, should be predominantly cardiovascular or cardiologists who have interest in pulmonary hypertension, heart failure cardiologists, and people from pulmonology, because there's mixed disease, as you mentioned. I think that's key. That if you want to be a comprehensive center, having a core faculty or core physicians that deal with these types of complex patients is essential. I agree with that. Now, I always joke with my residents and fellows, and I tell them what's common between pulmonary hypertension and the pulmonary department is the first name only. I think this is a cardiovascular disease that needs to be dealt with, within the home of cardiologists. With all due respect to my pulmonologist colleagues.
Yes. محمود في سؤال under name Galaxy أعتقد under name Galaxy دكتور خليل إذا كنت مش غلطان من السابق بس في الاس اللي with interstitial lung disease and end up with pulmonary hypertension. How would you differentiate if it was group 1 or group 3 on right heart cath? You did allude to this earlier with the numbers, but maybe you can summarize, Mahmoud.
Yeah, these are this is very hard. This is Galaxy. I don't know your name. So if you were to write your name or you can unmute yourself and we can discuss. But this is a group that these patients are very hard to treat. Now, let me try to correct something real quick for you. What is the most common connective tissue disorder that causes pulmonary hypertension? PAH. Awatif, thank you for clarifying that. So what the most common common connective tissue disorder that causes PAH actually is not SLE. It's systemic sclerosis scleroderma. Exactly. That's right. Leila, you there. Thank you. Systemic sclerosis. You're absolutely correct. And what's one of the hallmarks of systemic sclerosis or scleroderma is that a lot of these patients, independent of developing PAH, develop interstitial lung disease. Now you have two disease components or two disease processes that are causing the same thing. You have interstitial lung disease and you have connective tissue disorder. Both will cause pulmonary hypertension, and those are very hard to treat. Which is causing what? And we are usually faced with this issue. And usually, to answer your question, usually these patients end up on therapy anyways. It's hard, you cannot differentiate between them on right heart cath because both of them are precapillary disease processes. So you'll have very high PA pressures and very, very low wedge pressures. So you cannot differentiate between them on right heart cath. You have to sit down and bring everything to the table. Your cardiac imaging, your lung imaging, your your rheumatological data that you have, your serum biomarkers, your BNP, your prealbumin, your creatinine, your liver function, all that, and you come up with a plan for these patients. And this is where it becomes important to answer to piggyback on Ayman's comment. This is where you have a multidisciplinary team, including rheumatologists as well, because our team here includes rheumatologists as well. So very, very important. And that's a beautiful question. Thank you for the question, Awatif.
مش عارف إذا في أي سؤال تاني. لو ما فيش ممكن نسأل سؤال بسيط. هنرجع للإيكو مرة تانية. طبعا أنا نقول لو عندك أنت good TR envelope, الإيكو you cannot overestimate the pulmonary artery systolic pressure, but you might underestimate if you don't have good envelope. So الstudy اللي عملت correlation between الإيكو right heart cath. Did you look at the numbers when the numbers are high versus when the echo is like underestimating rather than overestimating? يعني معنى كلامي يفرض الايكو ادتك systolic blood pressure TR جت 4 by 4 16 by 4 64 add RA pressure maybe 8 like 71. Would it be good predicting and better correlation with the right heart cath? Well, just it's like too much thinking into it.
Too much thinking into it. I mean, and I don't think that the take-home message is that following. So let me try and simplify this. You have you do an echo. The TR velocity jet is 4. Okay, TR max of 4.
Yes.
Diagnose the patient with pulmonary hypertension. You do a right heart cath. You do all that stuff, and you do your intervention. I'm going to say intervention, whatever that intervention is: diuretics, heart failure management, PAH therapy, whatever. خلاص من هنا ما عادش تبع لي بالايكو، ما عادش دير ايكو، ما عادش تبع بالايكو، خلاص الايكو دار شغله. Now you follow with right heart cath. لأن you will be surprised that your echo will not correlate with your right heart cath. It may correlate 50% of the time. But in these very sick patients, do you really want to depend on a flip of a coin to manage them? And the answer is probably not. So that's why the echoes, that doesn't mean that you don't do echoes anymore. No, you do echoes for other purposes. You want to make sure the RV is okay. You want to make sure your tricuspid valve is okay. Your TR is okay. You do other, but not for the sole purpose of following the pulmonary pressures. That's what I'm talking about.
Yes. دكتور فتحي إدريس, تفضل دكتور فتحي.
السلام عليكم. Can you hear me?
I hear you well, Dr. Fatih.
Okay. Mahmoud, shukran jazilan. It's excellent presentation. I learned a lot. This is not my favorite topic. As interventionist and EP, this is one of the areas that I should say always been difficulty, and it's confusing. And like you guys discussed, there's multi partners involved in this, like pulmonologists, heart failure specialists, rheumatologists, etc. So I want to make a few editorial comments here, if you give me like 5 minutes at most. First, in regards to the who should deal with this, I think you clarified it clearly. I think this pulmonary hypertension should be a very focused centers and everywhere, and this is what at least we have here in the United States. You shouldn't be somebody treating pulmonary hypertension in every corner. This should be a dedicated center of excellence and with people who are dedicated to do this. As far as specialists goes, I personally believe it should be a fellowship by itself. Who want to do pulmonary hypertension, if you're a cardiologist or pulmonologist, because there's much more complex cases, especially those with congenital heart disease. They present with very complex, challenging stuff. Like they have open shunts, closed shunts, and pulmonary fibrosis and all this kind of stuff. So I think it should be a fellowship by itself. If you ask me this, who should handle this, should be a fellowship. You can go to it from either pulmonology, from lung, or from cardiology or vice versa, because it's very complex. It involves valvular disease, lung disease, rheumatology, etc. A second thing is a few comments about the right heart cath. I agree with Mahmoud. I think the echo longer term follow-up is not going to be your best tool. I think I am, again, and as an invasive cardiologist, I'd like right heart cath to give you a lot of information, simple tests. But again, at the same time, I should bring the caveat that if you do right heart cath, you be careful when you look at the data, because not every patient is just either type 2 or type 3 or type 1. Actually, many patients are mixed, and you need to be careful. Sometimes number one, you need to look, what you're looking at in terms of interpretation of the information. Sometimes you need to challenge a patient with fluid or etc. You may need to repeat the cath after they're dry to see whether there is any element of pulmonary hypertension has resolved after that. And I believe CardioMEMS, which Mahmoud had beautifully outlined, we use it increasingly here. It's a nice tool, very simple to put in the patient. But again, you need to have the infrastructure to monitor this carefully, because you're going to monitor the diastolic pressure. And in the slide Mahmoud brought here, if you look at the top left part of the slide, which is nice, you usually give a diastolic blood pressure for the patient. Every patient is different. Some patients diastolic pulmonary pressure, not blood pressure. So diastolic pulmonary pressure of, for example, 15, 18, 20, whatever, and then you give them a range, like this is your wet, this is your dry, and the team will monitor. And if the patient creep up or creep down, they can, it's a very nice tool. But again, I don't know whether there's an infrastructure for Libya to set it up or not, but it's a very nice tool to monitor the patient invasively and non-invasively at the same time, because you put that thing in the quick procedure, and then you can have good grasp of, and the Champion trial, which Mahmoud showed, is a good tool for that, to show that you can catch that ahead of time. Before that, we were able, if your patient has an ICD, you can look at the OptiVal, which OptiVal also can predict that before the patient. It's almost like a poor man technique of CardioMEMS, but it's a different way of doing that. Again, when you do a right heart cath, be careful, make sure you zero it good, your transducer is the level. You make sure that sometimes, we don't routinely do pulmonary, I should say, in a busy day, we don't routinely do pulmonary vascular resistance, but it's simple. If you calculate cardiac output, you have pressures, it quickly gives you the result of that. So you may need to make sure you do your cardiac output carefully, so you can calculate pulmonary vascular resistance if needed. We don't routinely do it, but if the patient is challenging or the information a little bit conflicting, I think it's a very useful tool. And today I learned from Mahmoud, it's two Woods unit instead of 3, which is a very nice update. Thank you so much. Again, appreciate it, Mahmoud, and good luck for everybody.
Thank you, Dr. Fethi. That's nice comments from your side. Let me see, there is a new message here, just in case we are not missing another question. Mahmoud, I've just asked last question from my side because there is no one else waiting. يوسف الغول بيسأل. تفضل يوسف.
You can go first, Mansour.
No, go ahead.
So, thank you, Mahmoud, for the great presentation. My question, and I was in this situation twice. Once when I was a third-year resident, and the second one when I'm like a fellow, like a couple of weeks ago. And first case that we had in the ICU, patient came with shock. And then we found out that he does have pericardial effusion with tamponade physiology. And he underwent pericardiocentesis. Couple of hours after that, he decompensated and died. When I went back to chart the patient, he did have pulmonary hypertension with RV failure. And then we had a big discussion about the situation, and again, happened in the ICU a couple of weeks ago, where cardiology team removed the whole effusion there at once. Fortunately, the patient didn't decompensate after this. With the same thing, pulmonary hypertension with RV failure, with pericardial effusion and tamponade physiology. What's your take on this, and what you would recommend for those people? managing the situation.
Yusuf, you are your observations and comments are spot on, and yes, absolutely, this is a very known phenomena. Folks who have chronic pulmonary hypertension, especially when your PA pressures are very high, you know, they will develop a pericardial effusion. You know, and the last thing you want to do, and you learned this the hard way because you learned it 2 times, and the 2 times the patients died, the last thing you want to do is touch that fluid. Touch that pericardial effusion, the patient dies. Why? Because remember, the RV is dependent now. It's, you know, the RV is faced with all this pressure up front, right? The RV is faced with a PA systolic pressure of 80 or 90. What's keeping that RV pumping and maintaining forward flow is that effusion. Now, all of a sudden, you take that effusion away, the RV has nothing to support it, and all that pressure that's building up upstream comes back to the RV dilates, and the patient dies from shock. So yes, a lot of times you see this, you see pericardial effusion in patients with pulmonary hypertension, and you know, the first thing that you want to do is you want to drain that effusion. And of course, this is all generalization, right, Yusuf? So, you know, I don't know the exact details and all that, but this is in general. We're talking about in general. So yes, I used to have an attending of mine. He's a you know, very experienced, been the chief of cardiology at Emory here for many years. It tells you, when you see that pericardial effusion and the pulmonary pressures are high, don't touch that effusion. So you know, very great observation, Yusuf, and thank you for that question. I hope I answered your question.
Yeah, Mahmoud, can I follow up on that?
Go ahead.
Yeah, it's an excellent question, and it's kind of dilemma in clinical practice. And I came across few cases with similar scenario: patient with pulmonary arterial hypertension who had large pericardial effusion, and you give the push or the urge that maybe if you can drain that fluid, patient would get better. If you look at the data, okay, anytime you drain that fluid, patient, they don't do well. And I think we're missing the big picture. The big picture is not the pericardial effusion. It's that this patient has severe disease, and that effusion is a complication of disease. It's like one of the prognostic signs of large pericardial of pulmonary hypertension, right? Either like syncope, 6-minute walk, and pericardial effusion. So I think once you see that, I think the elephant in the room, that the patient is very sick, he's gonna die soon. I think it's time to talk with the family about what's the next step, about like what's this patient's outcome, because if you drain that effusion, you may just accelerate this patient's death, and you think you did that wrong, but the underlying issue is that this patient already dying because of that. So I think it's important, don't get misled by that pericardial effusion. If you drain it, the patient would feel better. No, it's this patient has severe pulmonary hypertension, and that's an issue. Once you see that, you should think about goals of care and talk about the patient and the family. What's the next step? Thanks.
فيه الدكتورة حنان مقرحي، ممكن تسألي سؤالك والله إذا كان في إمكانية للدكتور محمود مباشرة، أو ممكن حنقرأ السؤال otherwise. الدكتورة حنان تسأل محمود، أحيانا المريض يجيك بالإند جيم بتاع البلمونري هايبرتنشن ولا left side heart disease. Now the RV is dilated and failing, and the blood pressure is very soft, and probably maybe renal dysfunction, who knows. How would you manage those? I know it depends on the whole case scenario, but in general, what would you do? Any piece of advice in this case?
Yeah, that's a whole lecture in by itself. Now you're talking about RV failure, management of RV failure. So can range from, it just depends, range from simple decongestion to inotrope support to mechanical circulatory support to you know, a lot. That's a whole different topic. RV failure and management of RV failure. We have it in our, inshallah, in our lecture series. This is a very advanced topic. We'll talk about RV PA uncoupling, and we'll talk about a lot of very exciting stuff. So yeah, so that's RV failure management. So depends case by case basis.
So I think we should end right there. We are exactly on time, Mahmoud. Again, Mahmoud, thank you very much. It's always enlightening and exciting to listen to your presentations. Thank you everyone for participating today. And hopefully we'll meet again soon with another exciting heart failure lecture. Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Shukran.
Wa alaikum assalam. Thank you, everybody.